Yes, good evening, everybody. First of all, thank you very much for the personal invitation. It's my first time in Bulgaria, but I definitely like it to be here, and I think it will not be the last time, I hope. And of course, all the nice setting and all this nice meeting that I attend for the first time, even if it's the 5th edition already now. Okay, now I want to focus a little bit on general aspects of this topic and on some surgical aspects. I know that you are not all pancreatic surgeons, so I try to be also a little bit general on things that can also be transferred to other diseases and other operations. So what I want to talk about is a little bit about centralization, standardization techniques, and for the end, evidence-based medicine that we all need to do in 2026. I will show you why. Why do we need centralization? This is very easy, and this has been described for the last century. These are the historic complication rates of Whipple operations, of pancreatic operations, and you see that this is not acceptable. This is between the 1960s and the 1970s, and of course all of this was a reason for this very famous citation that the Congress in the United States should make it illegal to perform a Whipple operation. This should be forbidden. Of course, this did not happen, fortunately. It developed much further. And you know all these stories. That was more than 20 years ago. The more you operate in your hospital, the less complications you have, and the lower your mortality after these complex operations, esophagus, pancreas, liver, sarcoma, all of these things become. And of course, the second thing is the surgeon. If you do a pancreatic resection 4 times a year, this is already enough to come down with your complications and also with your mortality. If you do it once a year or once every second year, you should probably stop doing this. So these are some very good arguments for centralization. You think this was the 1950s and 1960s. I want to show you some data from Germany, 2025, published in the British Journal of Surgery. These are registry data all over Germany. Pancreatic resections, the most complex, is the total pancreatectomy. You take out all of the pancreas. You can do this as a type 1 only, the pancreatectomy, type 2 when you also resect the portal vein, type 3 when you resect an additional organ, for example, the colon, and type 4 when you also resect either the mesenteric artery or the hepatic artery because of tumor infiltration, and you need to do this. This is an example how you can do this. Take out all of the pancreas, take out the right colon because the tumor was invading the mesocolon, reconstruct the hepatic artery, reconstruct the portal vein. All of this is possible. These operations have been performed in Germany increasingly. This is the number of total pancreatectomies all over the nation. You see between 2010 and 2020, steady increase, also for this very complex type 4 with an arterial reconstruction. And what you see here is that, of course, the more you do, the more complications you have. This is not very hard to understand. The more operation, the more trauma, the more complications. But what else you see? You remember the so-called historic mortality rates. This is reality in Germany, 2025. You see a mortality of 35% in hospital for this complex operations performed nationwide. This is all over the country. What is the reasons for that? The reason, of course, one is the comorbidities of the patients. The sicker the patient is, the more dangerous the operations get. This is shown in this table. I think this is also self-explaining in some way. But the most prominent risk factor is the surgeon. You see, if a surgeon performs this once a year, he should not do this. If a surgeon performs this at least 10 times a year, this becomes much better and the patient has a chance to survive the operation, not the cancer. The operation as the first step and leave the hospital. Why does this not work? I will show you Hamburg. This is the situation of my city. Blue is our university hospital in the middle. All the red spots are so-called pancreatic centers. 9 of them in a city like Hamburg, they call themselves pancreatic centers. And this is a city of 2 million inhabitants. So you can make up your mind yourself, does that make sense? Or maybe we have to centralize a little more. And to make it even worse, these are some data that you can check in the internet. This is a German university hospital. I will not tell the name of this hospital. And these are quality report data from 2024. What you see is they perform, in average in Germany, 8% mortality in pancreatic resections. And this hospital, University Hospital Germany 2024, has a mortality of 22% for these operations. So you see, this is reality, and that's why I want to emphasize this centralization and, of course, a minimum requirement of caseload. In Germany at the moment, it's 20. You can perform 20 pancreas resections to be allowed to do this. But you see that even this hospital does some 48 and has a mortality of 22%. So 20 is certainly not enough to do a good performance and to not danger your patient in the hospital stay with your pancreatic resections. Next thing, very briefly, some little surgical excursion, standardization, definition, and techniques. What is the state of the art from my point of view? I just want to focus on 2 or 3 things. First thing, what you should do every time you want to perform pancreatic cancer resections is check your arteries. If you have a CT scan like this, you know this tumor is invading the arteries. You don't need to check this artery. But sometimes it's not so clear, and therefore you should always use an artery-first approach, which means you go to the mesenteric artery or the hepatic artery in the first step of the operation before you have transected the stomach, the pancreas, the small bowel, the bile duct, because then you see an arterial infiltration and you can stop if you are not sure that you can get this out radically. Otherwise, you don't do a favor to the patient. If you do an R2 resection, the patient doesn't benefit from that. This is especially true in the era of neoadjuvant therapy. You need artery first, and then you can go for radical resection. We have called this the triangle operation some years ago. This is how it works. You have neoadjuvant treatment. You have the CT scan after neoadjuvant treatment. You explore all of the patients who do not progress surgically. You go to the artery first. You take your frozen sections there. If they are negative, you can perform a radical resection. And this is an example how you can experience that. CT scan after FOLFIRINOX. Which radiologist would tell you this artery is free or this artery is not free? No radiologist would ever tell you this finding. In the operation room, it can look like this. You can free the arteries completely, the mesenteric, the hepatic. You don't need to resect them because you had a good neoadjuvant treatment before. And you take out everything between the portal vein and the arteries. And that's what we call the triangle. And this is also a principle that I think should be state of the art for cancer resections in the pancreas, not for IPMN, not for any benign lesions. Then you don't need this extensive dissection. But for cancer, you should probably do this. If you don't do this, you all know these pictures. First control after the operation, 3 months, then 6 months and 9 months. You see a clear recurrence in this triangle area, especially around the large vessels. Does this turn out into some better results? This is a nice study from China, published just recently. Triangle versus non-triangle, 52 versus 55 patients. What is the results of this study? You see here very briefly, you have a higher number of lymph nodes that you can take out with this. That's not very striking, I would say, but the important thing is shown here. The patients without the triangle operation on the right side have a much higher rate of local recurrences. This is triple high than those who had the triangle. Of course, they then progress systemically, but as a surgeon, you can contribute to reducing your local recurrence by being a radical surgeon with this. And then you might offer also a better benefit regarding the prognosis. And this is also shown in the Chinese study. Just look at the right side and the blue line. This is triangle and full course of adjuvant chemotherapy. This is the best you can do. The other curves are triangle and non-full adjuvant therapy, or non-triangle plus adjuvant or non-full adjuvant. So I think this should be kind of a state of the art today, what you expect from your surgeon when you go to a hospital for having a pancreatic cancer resection. The portal veins are also, for quite a long time, in the meantime, state of the art. You see these pictures. You can resect these portal veins with a tumor infiltration. You can reconstruct these portal veins also with the splenic veins. Just very briefly, what is the experience that you have when you do this? These are data for a 12-year period, 700 patients with portal vein resections of any type. And I just don't want to go into the details of the reconstruction because this is very surgical. The important thing is finally the survival. And you see when you can take out everything radically, really are zero resection, negative margins, 46 months is possible with this type of surgery. Now for the last thing, what is going on at the moment? What is the future? What is the evidence that we have? Of course, the big future is the robot at the moment. Everybody debates about it. Everybody tries to set up a robotic program. Everybody tries to do not only colorectal, but also liver resections, pancreas resections, whatever other resections, thoracic anyway. Why should we be a little bit careful? Because we have made experience from new innovations in the past. And I want to go back to this study you may know from the New England Journal in 2018. This was completely different gynecological study. Early stage cervical cancer. This is a disease you can cure by operating the women. Somebody had the idea to do this minimally invasive with a laparoscopic approach. Everybody was happy, no scars, very nice. And nobody thought about it. Since 25, I think that was going on in the United States. It took 13 years until this study was published, a clean, randomized controlled trial, laparoscopic hysterectomy compared to open hysterectomy. What you see is that the laparoscopic women died 15% more after 5 years than the ones who had an open operation. So there must be something wrong with the operation. And this is the reason it was a very early local failure, comparable to the pictures I showed you for the Whipple resection, because it was just not radical enough by this fancy new approach of laparoscopy. Everybody wanted to have it, everybody wanted to have no scars. Cosmetic is very important, of course, but survival is more important, I think. So we need to be careful. Can we do the same with the pancreas and the robot? We have described this some years ago. We can do the triangle with the robot. This is possible. You can achieve the same clearance of the soft tissue in between the vascular structures that I showed you in an open fashion. And then we also created some evidence. And I think with the robotic Whipple, we were not that bad. We started about 10 years ago. And today we have finished 3 randomized controlled trials in the world on robotic versus open Whipple, not as the cervical carcinoma and the laparoscopic hysterectomy, where it took more than 13 years until 1 RCT was performed. This was the first we could finish, 40 versus 40, of course not very large numbers of patients. However, they were balanced very well, and you don't need to go into the details. It's exactly the same regarding the outcomes. The only significant difference is, surprisingly, the costs. Of course, the robot was significantly more expensive than the open Whipple procedure. This, again, is too much details. Oncologically, radical parameters, harvested lymph nodes, R0, not R0 resections were exactly the same with the robot. The proportion of patients who proceeded to adjuvant therapy afterwards was exactly the same. What a little bit disappointing was the outcomes in the quality of life. The robot did not offer any advantage to any patient. Also, the length of hospital stay was exactly the same. It was just more expensive. Was it our failure? I'm not sure, because these are meta-analyses that we could just now publish on all the evidence we have at the moment, 3 RCTs, 4 cohort trials. In the meantime, more than 1,400 patients, very balanced, again, open 7-20-20, robotically 7-18 patients. And what you see here is, just look at the diamonds in the middle, not all the parameters. Fistula, bleeding, the pancreas-specific complications. Delayed gastric emptying, pancreas-specific complication, exactly the same, open or robotically. Length of stay and readmission. Length of stay maybe a little bit towards the robotic approach better. We talk about 1 day earlier discharge compared to the open Whipple procedure. In average, through all of these studies, no more readmissions. That's at least good. And the important thing is shown here, no higher mortality, which means we don't harm the patients with a robotic approach when we do this. This is the first 3 RCTs and 4 big observational studies that we analyzed here, so it should be non-inferior at least. If it is superior, we will see in the future. We are waiting for Shanghai's Portal trial, will be published this year. This is another large RCT on the same topic, and of course, most importantly, the Diploma 2x2 by the Dutch study group. They have now focused on the cancer outcomes. You remember the story with the hysterectomy. Is this also equivalent in terms of only looking at the cancer patients? And the good thing is that this study has now completed the recruitment. These were the centers that were participating in the study. You see all over Europe, it were about 18 centers, I think. And the recruitment is just this week completed. End of March, last patient in, 3 months observation, then another 2 years observation. However, the first results we will have probably by the end of the year, and this will be the next milestone to create some evidence in terms of, is it also suitable for oncological indications alone? Now, for the future, why did I tell you all of this? What do we expect for the future? We could say the robot is not better, so forget it. This will not happen, I can promise to you. This is just a survey among surgeons. 315 surgeons participated in countries all over the world. What is the robot going to be in the next years in pancreatic surgery? What you see here is status today: distal pancreatectomy, mostly laparoscopic in yellow. The Whipple, mostly open in orange. This is the status today. When you go for any extended procedures like vascular resections, multivisceral resections, blue is open surgery. So this will continue to be open also in the future. However, the standard Whipple, also for cancer, you see on the right side, orange is the robot. The robot will continue, the robot will increase further, and we will not switch the turn back. We will have to face this and we will have to work with this. I personally am a fan of the robot, but right at the moment we can only prove very little superiority of the robot, if ever superiority, in these pancreas procedures. This looks different for other organs, but for the pancreas this is the status at the moment. However, this is what surgeons expect. The future will be robotic also for the pancreas. Thank you very much for the attention.